Good afternoon. Well, thank you very much to all of you for being here. We'll be brief so that we can start the session as soon as possible, as we are starting delayed, as you know. So it's a dream come true. So it's an apt name that this symposium is called Symposium on Dream OCT. And I trust that you will agree with me when you start seeing the images. So without any further delay, I would like to introduce the first speaker, Professor Yali Jai from the KCI Institute. Yali, many thanks for sharing this pioneering work.
Thank you, Paul, for the introduction. It's really my pleasure to speak in this room. My slides, please. I do have a financial interest in OptView, optos, genetics. I do got the material support from Intalight. Okay, here we go. I slightly changed my title because my previous inherited disease due to some study protocol delay. I have to switch to a different type of disease we scanned. I'm gonna share my experience, just the 2-month experience, to show how ultra-wide structural and angiography OCT of DR. There's some dilemma here, right? If we have the founder's photo and the fluorescent angiography in clinic that generate a super wide image, but our OCTA always being complained by the small field of view. And I tell you some pain I go through since 2015. I start 200 kilohertz swept source OCT in the lab, but at that time we have to do those full montage. We identify those very important neurovascularization that's beyond the image region can be generated by the regular size 3 and 6, right? Then even using those montage, the regular commercial system, we find that those retinal neovascularization is really noticeable on the founder's photo, but it's really visible in the OCT. So we continue to discover this very tiny subclinical neovascularization in the diabetic retinopathy. So, for example, in this case, you could see that clinically look like a dot or the hemorrhage on the founder's photo. They must miss it in the clinical disease, but it's clearly shown by those depth resolved cross-sectional overlay image. And using those 3 montage 9x9 image, we also find that those very tiny subclinical retinal neovascularization. Again, it's also look like a dot hemorrhage on founder's photo. I would tell you, if you thought wide field can solve everything, that's not true. Actually, those tiny spots could be very small, so we also need to maintain the resolution. In a very high resolution scan pattern, we generated this on-fast OCTA from the inner retina. You could see some of those a little bit bigger neovascularization. You could see both angiogram and the vitreous slab, but that's tiny areas, those identified by those colorful arrows. It couldn't be identifiable in the angiogram. You have to use those overlaid cross-sectional image to see the blood flow in those tiny spots. So ideally, we need a wide field and high resolution in the same system. Building a high-performance imaging OCT platform is not easy. Just like super fancy camera, you do need the wide field lens, high-speed camera, high-performance data processing, real-time image display, motion tracking, and OCTA imaging processing as well. So all those steps, all those components should be perfect. Then you generate the perfect image. I go through every those step by recruiting the hardware engineer and the software engineer. It's a lot of challenging in each step. I just want to share you. It's a lot of a lot of experience goes through from 2015. You know, we have a 200K to our recent, those 500K prototype system. And then we struggled on extend the imaging range. We use a dual beam to boost the speed. We have the GPU-based real-time processing and a non-metric testing and the self-tracking method. A lot of those component we have been worked. That's the image we generated in the lab compared to the central macular generated by the conventional size. Now that's 23. That's the maximum we can achieve in the lab. Now we have a dream OCT, everything be achieved in the same modality. It can do the biometry and it can do the anterior segment measurement, but today I just want to focus on the retina posterior segment. That's the image from my eye. So you could see 12 by 12 millimeter, 18 by 18, and then even bigger, we could generate those 130-degree angles. The actual size is 26 by 21. Actually, this 130-degree is the eye angle measurements. It's equally same as the opto's measurement from the center of the eye. I show you some pathology images now. That's the case from a mild non-proliferative DR. So you could see that's 12, 18, and even bigger. So the image still maintain the very high resolution. The sectional image, we already flattened just to improve those visualization here. Show you a case from retinal neovasculature in the proliferative diabetic retinopathy. So you could easily identify in this smaller, relatively smaller field view. So you could identify two. Even bigger, you could see those little sprouts and extended. We could reveal those two mist on the edge on the left. And all those spots can be reviewed by both structural OCT and OCTA. And those colorful image is very helpful. This is generated by the depth resolved, the slab resolved overlay. So you could see the retina normal angiogram overlaid with RNV and overlaid with a choroidal vasculature from the same scan. So compare with the fluorescein angiography, you could see all the neovascularization generated or detected by OCTA. Actually, it's some corresponding to the NV identified with a leakage, some with not. Like on the left, some small spot neovascularization. Actually, on the fluorescein angiography, you probably identify as ARMA. It's no leakage at all. So OCTA may be a game changer here. You know, we could really help us to identify those different type or different stratify those neovascularization here. I want to show you bigger or larger wide field view also can catch those non-perfusion areas, ischemic areas easier. For example, in this MPDR case, the non-perfusion area predominate in the periphery area, right? If you just use 12 by 12, 18 by 18, you couldn't catch all. So if using this single scan, 130-degree, we almost catch most of those non-perfusion area. So that may change, you know, the staging, DR staging protocol in the future. If they can base the OCTA, that's totally different from other founders' photo grading on DR. So that's another color-coded. By the way, that's the comparison with the color founders photo. I want to remind you the ischemia area is very clear on OCT, but you couldn't really see from the founder's photo. And the software we used to detect those non-perfusion area actually is all the deep learning areas we developed on the small side of view. We didn't do any optimization. It's just directly used. They can apply on it. So that means, super wide field view OCTA plus some advanced deep learning algorithm, this can make our life easier. I want to show you, don't forget about structural OCT. Structural OCT also contained or remain a lot of information. For example, in this non-proliferative DR case, using those wide field view scans, we can easily screen where is the flow retinal is. So basically, we generate a retinal fluid volume from this entire 26 millimeter scans. You could see those very tiny fluid in the central macular areas. And that's quite a very similar or identical to the retina thickness location. You could see, the location is really identical. And compared to the clinical thickness image generated from clinical available system, you could see this dream OCT really extend our field of view, extend our our vision to see the periphery areas. That will help to further screening the fluid in the periphery areas. Oh, go back here. I want to emphasize again for the deep learning usefulness here. We also applied a very published method algorithm, retinal fluid detection algorithm using the deep learning on this new scan we never seen from the neural network, but it still work. We still detect the right position. And for the photoreceptor more function of photoreceptor disruption, here we show it the slab from EZ, very thin slab. You could see compared to the healthy, this severe NPDR shows the loss. The defect is very apparent from those en-face image. A few years ago, we work on the photoreceptor defect area, actually just focus on those green rectangle areas. It's very small, just 3 by 3. If on this case, you might not really identify any defect, but using a wider field view, we can check the defect mainly on the periphery area. And this defect also very visible on the cross-sectional as well. You could see on the left side, that's en-face and cross-sectional is correspond. And if you're interested in to study choroidal vasculature, that's also could be generated from the same scans. Healthy and PDR, you could check the vasculature difference. You also can check the thickness difference. Apparently, in this one pair case, those case is age match. It's an axial length match. Basically, the difference is mainly due to the choroidal thickness change. And also, choroid capillaries might be a very interesting layer to check. So compared to healthy, that's the image just automatically generated from the system. I just changed the color only. I didn't do anything. But apparently, from those 3 images, already shows a central macular defect on the choroid capillaries slab. It's maybe show something. I would say due to the limited number of group, I couldn't make the solid conclusion now, but it does show something on the choroid capillaries. Let me conclude. wide field, or ultra-wide field, and high-resolution OCT and OCTA really desirable to detect retinopathy in its early stage. And building a high-performance wide field and high-resolution OCT and OCTA, it's really need many kinds of expertise. Intalight OCT achieved those capillary resolution in a single angle with 130-degree field of view. And this type of OCT, OCTA will reveal more features in DR, not just the DR, many types of retinal disease in conjunction with deep learning we already discovered. So I would acknowledge the material support to my study from Intalight. I really enjoy the pleasant experience with this DREAM OCT. And I also want to acknowledge my PhD student who provided these slides within a very short time. And okay, that's it. Thank you for your attention.
Thank you very much, Yali. We'll take questions after the three speakers. We will take questions after.
Okay. So it's my pleasure to introduce Professor Paolo Stanga. We are going to navigate through the vitreous body. Probably the dream come true.
Thank you very much, Adil and Yali. Many thanks to Intalight for this invitation. Let me share with you our experience using this new technology. I'm a clinician. I'm a vitreo-retinal surgeon. So I'll change gears a little bit, and I'll show you how we benefit from this technology on an everyday basis and how it changes the clinical management of our patients. So these are my commercial associations. So I have a special interest in the vitreous. Yesterday, I chaired a 90-minute session on vitreous floaters and how to manage them. So we know that the vitreous undergoes liquefaction as we age. And this is because collagen fibers aggregate because they lose hyaluronate and collagen type 9. So we know that the vitreous also undergoes two processes, mainly synthesis, which is vitreous liquefaction, the coalescence of cisterns, and the aggregation of collagen fibers, and which subsequently lead to syneresis, which is the vitreous collapse or posterior vitreous detachment, PVD, as we tend to call it. The diagnosis of PVD is not standardized, and people do tend to say, well, if there's a sudden onset of floaters, you must have a PVD, when there could be a vitreoskisis. And it's also important to be able to tell the patient what the other eye is doing. Is there a PVD in the other eye? Has the vitreous started to separate from the retina or not? We need to objectively establish the presence of PVD. It is sometimes difficult to find a vice ring on biomicroscopy, especially in a high myope, especially after PVD has been present for a while and the vice ring may have reabsorbed. Why is this important? Because we need to provide prognosis to the patient. We need to know whether the patient is out of risk of retinal tears. There are treatment options for vitreous floaters as well. So we need to be able to counsel the patient based on data. It is important to know that 1 or 2 out of 10 patients develops tears as a consequence of acute PVD. 3% of patients also can have delayed tears, so delayed onset tears after PVD. So you want to know whether there is a PVD or not. Of course, all of these patients need to undergo indirect ophthalmoscopy with scleral depression. So it was Tolentino back in 1976 who came out with the concept of complete or incomplete PVD. In 2014, we published our series of patients, which was the first imaging paper in vivo showing the bursa primacularis and the space of Martigiani in a cohort of patients that extended between 5 and 100 years of age. And those are the images from our paper. This was the Topcon system, Triton, and here you can see the bursa primacularis, the space of Martigiani, and clearly visible as well as the wrinkles on the posterior hyaloid. OCT has undergone a revolution. We no longer image with OCT the macula. We image the macula and beyond. With the Canon technology, we started looking beyond the posterior pole to the point that we also published a paper on 3D rendering of images and how helpful this is for a vitreo-retinal surgeon. So it is important to image the vitreous to objectively establish whether there's a PVD or not. So now we have this device, the Dream OCT, and as I'm sure you will agree, this is a dream come true, because for years we've wanted to image beyond the macula. We've been able to do this for some years now, for a couple of years, but we also want to image deeper into the vitreous. We want more than 2.5 millimeters of imaging capacity. And this is what we are achieving now with this device. As you can see, we go deep into the vitreous, a 12 millimeter deep window, swept source OCT technology. So as a comparison, this is a standard 12 millimeter long scan, a single scan with 2.6 millimeter window, a 16 millimeter scan, 3 millimeter deep window, 23 millimeter scan, that's already wide field with 5.3 millimeter window, and this is now the Intalight device, 26 millimeter, 130 degrees with a 12 millimeter window. So how helpful is this on an everyday basis? And here you can see an eye, you can see a nice breach over the bursa primacularis. You can see that the vitreous is clearly attached, and you can see the system of cisterns, but we can also see that the vitreous is attached peripherally, and you can see the increased content of collagen fibers in the peripheral vitreous cortex. This is a 3D rendering. You can see the presence here of a nice staphyloma in a high myop. You can see the presence of macular, well, not macular, extramacular peripapillary myopic schisis, and all of this information is very useful to me as a vitreo-retinal surgeon when I need to treat, when I need to operate a myopic patient with myopic macular traction, or traction myopic schisis. This is a patient with a vitreofoveal attachment. If I scan just the macular area, I don't know for how much of detachment there is in the perifoveal area. With a long scan, I know how much I need to detach, or whether I need to detach intraoperatively or not. It is very common that we see patients with vitreous floaters, and vitreous floaters can be treated. It is wrong to tell patients that they need to put up with floaters. Not every floater needs to be removed, but when they pose significant problems to the patient, they can be treated. And we published this new methodology for the assessment of vitreous floaters. And let me show you this example. This is a patient with barely visible floaters, and here we can see the fundus before selective vitrectomy, here after selective vitrectomy, and the scans clearly show what we are doing. We are selectively removing the core vitreous floaters. This is before and after selective vitrectomy surgery. Here you can see the remnant of cortical vitreous that we leave behind. We are not removing all of the vitreous. We no longer need to do this. This is a patient with nasal retinoschisis, and here you can see the benefit of having a wide-angle scan in a myope patient. If I had scanned just the macula, not only I would have missed the presence of an attached vitreous, but I would have missed the schisis nasal to the disc. And here I'm enhancing the visualization of the vitreous. You can clearly see the space of Martigiani, the spurs, the bursa primacularis, and the system of cisterns. This is an enhanced visualization of the vitreous obtained with this device. This is peripheral schisis. Again, very useful when you want to differentiate peripheral schisis from peripheral retinal detachment. A patient again with vitreous floaters, and here you can see the shadow cast by a floater. But this floater is not close to the retina. And because I have a 12-millimeter window, I can clearly image the floater. I can explain to the patient the reason for the symptoms. I can document this. Not only this, I can document the presence or absence of a PVD in the fellow eye. Retinal detachment, I can clearly document the extent of a retinal detachment with ultra-widefield OCT. And here you can see in a patient that presented with a large horseshoe tear, the presence of an asymptomatic retinal detachment. The patient was initially treated with laser, did not respond, and subsequently underwent a vitrectomy. Here you can see the area of detached retina far away from the macula and therefore asymptomatic. And this is post-vitrectomy, post-treatment. This is at only 1 week post-treatment, a successful response to therapy. Not only we can view this on ultra-widefield multi-wavelength imaging, but we can document the absence of subretinal fluid, the thinning of the neuroretina secondary to the laser treatment. We are now benefiting from ultra-widefield OCT angiography, and I think the best application of OCT angiography today, based on technology that's currently available, is in the management of retinal vasculopathies like diabetic retinopathy and vein occlusion, because it can easily clearly show the areas of non-perfusion and the presence of neovascularization elsewhere. And here you can see a patient that underwent fundus fluorescein angiography. This is Heidelberg technology, the presence of macular edema, and this is ultra-widefield OCT angiography, so you can compare the results and how easily you can see the areas of non-perfusion in a non-invasive way. This is a single scan imaging and not a montage. That's 130 degrees. So this is how we benefit from this technology in real life. This is a patient with multifocal Vogt-Koyanagi-Harada, and this is multimodal imaging. This is the way we assess these patients. And here you can see the multiple areas of serious detachment in this patient. Intermediate uveitis, and this patient was complaining of a cloud, a very cloudy vision. Not only, of course, you see a hot disk there, and you see peripheral vascular sheathing and vitritis. But here we can clearly see the vitritis, and we will be able to objectively establish opacity of the vitreous secondary to the vitritis. This is a patient that was referred to with a diagnosis of macular hole after complicated cataract surgery carried out elsewhere. You can see that there is corneal edema, the significant corneal edema. And you can see, in spite of the corneal edema, the opacity, the quality of the scan that we have obtained in this patient. A myopic patient, it can be very difficult to focus on the macula in a myopic patient. And here you can clearly see that in spite of the myopia of -20, we are obtaining a high-quality image in spite of the -20 and the macula involving posterior staphyloma. You can see the presence of a macular hole and the presence of tractional macular schisis and the presence of atrophy of the RPE. Peripheral hole. It is important to image peripheral holes because we may believe that there is no traction, we may believe that there is no associated fluid, and you get a surprise when you scan these holes and there is the presence of elevated edges and the presence of subretinal fluid. If we want to follow up these patients rather than treat them, you really need peripheral OCT. And this scan, so peripheral, was obtained through an undilated pupil. Of course, we do our scanning through a dilated pupil, but this is to show how good the image can be even through an undilated pupil. And you can objectively establish the amount of subretinal fluid there. I would like to finish my cases by showing you this case of proliferative diabetic retinopathy. But please pay attention to the amount of cortical cataracts, the amount of lens opacity that you can see in this patient. So cortical cataracts affecting the visual axis, nuclear sclerosis as well. This is an ultra-widefield multi-wavelength image that, as you know, bypasses media opacity. And in spite of this being confocal, we're still getting the opacity on the image. This is the corresponding ultra-widefield fundus fluorescein angiogram, and this is the Intalight, the DREAM OCT, single scan OCT angiography of these diabetic patients. You can see how we can clearly see, much better than on the ultra-widefield fundus fluorescein angiogram, the areas of non-perfusion and the secondary neovascularization elsewhere. And this is straight after targeted retinal photocoagulation. So I wanted to finish with this case because I think it clearly shows the advantages of this technology. So in summary, this is non-invasive, fast acquisition, peripheral and central OCT imaging. We can image not just the cortical vitreous, but the deep vitreous with a deep imaging window, and I find this clinically useful. And this is very important to me as a clinician. So these are not just pretty images, these are clinically useful images. So thank you very much for listening. It is a pleasure to introduce my co-chair, Mr. Adil El-Maftouhi from the Centre Ophthalmologique de Rive in Switzerland.
Thank you to the Intalight team for this kind invitation. I'm going to try to demonstrate the clinical benefit of the DREAM OCT in my daily practice. The DREAM OCT constitutes a big step in OCT development, with a very wide scan of 26 millimeters and very high depth of 10 millimeters, of 12 millimeters, both in retina OCT and also with the anterior OCT with the 16 millimeters. We're going to talk about the anterior segment OCT. You can have a whole anterior segment images to the epithelium, corneal epithelium, up to the posterior crystalline lens. You can also identify the scleral spurs and the trabecular meshwork. You can easily obtain anterior segment biometry, but also crystalline lens biometry. It could be useful when you have a big bag to indicate the using of ring capsular tension, especially for the toric IOL. You can identify with the dynamic approach the inverse pupillary block in case of pigmentary dispersion, or in case of the risk of angle closer glaucoma, with a very nice view of the angle, nice view of the scleral spurs, and you can simulate the Van Eyck sign. Anterior segment OCT can bring a multimodality approach, both with a B-scan and with the en-face OCT, useful for refractive surgery. You can measure the flap, the stromal, the residual stromal bed, and also with the en-face OCT, and navigate through to the cornea. And look, in this case, about scare within the flap, you can easily identify the lesion, and you can also measure the flap diameters. In this case, you can highlight the microfolds of the flap, inducing light scattering, and this is the drawing done by the patient. You can also make meibomian gland imaging and to analyze structure and a function with OCT angiography to analyze the vessel density in case of blepharitis, and you can analyze before and after IPL. You can have also corneal topography embedded in the DREAM OCT. It's useful for the keratoconus screening before refractive surgery for the follow-up, and you can also analyze scleral lens fitting. For the ICL, you can obtain easily the distance between scleral spurs to the scleral spurs. It's useful to using Nakamura formula to help the sizing choice of ICL. You can follow the vaulting after the surgery. You can identify easily the opacity within the IOL. And look here, you can see the opacity in the anterior part of the lens and the posterior part of the lens. OCT angiography of anterior segment is now very reliable due to the speed of the acquisition, and you can avoid the eye motion artifact. And in this case of limbal cell deficiency, you can identify corneal new vessels. Iris OCT angiography is very easily, and now you can compare with neovascular glaucoma with the increase of the vessel density. So for the anterior segment, DREAM OCT bring modality approach with a B-scan, en-face OCT, and corneal topography. For the posterior pole, you can change the depth during the acquisition up to 3 millimeters, 6 millimeters, 9 millimeters, and also 12 millimeters. It's very useful to scan myopic staphyloma, like in this case, to identify the structure of vitreous body also, and you can identify the systems. And look here, you can analyze the cistern moving, and we know the cistern increase with age, and this is a dynamic approach. And you can use also en-face OCT here in PVD stage 4, and you can see in en-face OCT the folds of the yellowied posterior. And look here, the moving element of vitreous body in a dynamic approach. Vitreous analysis is very useful to understand some retinal reaction in the peripheric area. In this case, you can see the anarchic direction of intravitreal fibers explaining the reaction of this plane retinoschisis. In this case, in the bullous retinoschisis, you can analyze the details about the architecture within the retinal schisis and to analyze the risk of the conversion to the retinal detachment. And look here on the case of retinal traction with a small retinal detachment, but without no hole. Retinal detachment, a complete retinal detachment with a high depth is very easily to scan. For the OCT angiography, one shot is very comfortable. The time acquisition is comfortable both for the physician and also for the patient. And look here, in case of the Hill's disease, you can see the non-perfusion area, but in this case, no new vessel. In PEDR, you can also identify the new vessel. And look here at the left position, there is no, the perfusion of the macular area is normal, but you have also non-perfusion area in the peripheric. And we can have a very wide view with montage, and here the presence of the new vessel. You have a good tracking between each visit due to the confocal SLO, and you can analyze the changes of the new vessel and the reduction of the vessel density after intravitreal injection. OCTA is very effective because you have a very nice segmentation of Brooks membrane trained by deep learning. One of the challenging cases in OCT angiography is vascular PED, because it's sometimes difficult to make a good segmentation of RPE and Brooks membrane. With DREAM OCT, the segmentation is trained by deep learning, and now in this case you can easily identify the CNV within the PED. And here, in case of PCV, and before and after the PDT, you can observe the reduction of vessel caliber. We can also obtain a very nice and easily colloidal topography with a structure en face OCT, and you can also have mapping, as already said, GR, and you can analyze very easily colloidal hemangioma. With the en face OCT, you can see here a very nice pachychoroid in inverse images, and you can have also colloidal vascular index with the software. Parametrics analysis is also available with non-perfusion area, vessel density, flow area, phase quantification, and small vessel density. And now I can't resist to present the upcoming near future of the OCT with OCT with 400,000 Hertz, and look with a wider view of 220 degrees. And look here, the colloidal topography with a beautiful view of the vortex, and look here in case with a non-perfusion area. So, in conclusion, OCTA wide field will become soon a gold standard through wider, deeper, and faster acquisition, depth and wide increasing simplify OCTA wide field acquisition, and anterior segment OCTA is more reliable due to high-speed acquisition, and a combo machine with anterior segment OCT, B-scan, and corneal topography, plus biometry, bring a beautiful combo machine. And thank you for your attention.
Thank you very much, Adil. Fantastic images. Now you understand why it's called DREAM OCT. When you have representatives from all the imaging companies in the room looking at these images and taking photos for internal discussion, I'm sure that means something. Yali, can we ask you to expand a little bit on resolution?
Yeah, I apologize. As the first speaker, I didn't put all the parameters on my slides. I thought probably you both will do. That's in my mind. I remember the device I received, that's also 200K, right? You particularly want to know if the resolution. I think a transverse resolution about 20 micrometer, that's really depend on the optics design, right? I'm not quite sure the spot size on the cornea, but the spot size on the retina is about 20 micrometer. And the axial resolution is 5 micrometer. So it's quite a standard for the swab source OCT on the central wavelength, 1060 nanometer. You know, it's quite equivalent to the prototype in our lab. We also transverse 20, axial 5. But the nice thing for DREAM OCT, they apply the artificial intelligence on the angiograms they project on the en-face image. If you directly just show the angiogram, without any post-processing, you probably see some tiny lines. Even they have the very good tracking system, right? The SLO tracking, but they still have tiny lines if just to do the direct projection. But their image shows up, the final image, they applied the deep learning based enhancement algorithm, which is very nice. So the users can see the very clear vasculature very well. So the imaging depth you already demonstrate is 12 millimeter. In tissue, in air, it's even bigger. In air, it's about 16 millimeter. And when you image the smaller size, you could reduce those. You can very easily to choose. Can reduce your imaging depth. That can save the the GPU saving. That's make the saving very. The speed, the budget improved. So you could change to 6 millimeter imaging depth when you image the smaller area. When you image the bigger with a larger angle, you can extend to the 12 millimeters. So I think that's a very nice function. They have the trade-off between the imaging depth and the imaging size. What else? Parameters I missed.
I think you've covered. I think you've covered everything. Thank
Okay,
you very
great.
much, Adil. Fantastic images. Can you expand a little bit on how do you benefit on a daily basis in your clinical practice in the imaging of AMD, using OCT angiography?
Yeah. Before OCT angiography was time-consuming, depending of the time of acquisition, and now for the daily practice, you use a scan of 6x6 and 9x9, and is faster than before, and it's very easy to introduce OCTA in daily practice, especially for AMD.
Thank you, Adil. Do we have any questions from the floor?
For you, Paolo, how often do you use this technology in your daily practice?
Thanks very much, Adil. Every day. Every day, to be honest. Every patient that comes to see me undergoes ultra-widefield multi-wavelength imaging before seeing me. And now every patient that comes to see me also undergoes Dream OCT imaging. We specifically want to image deep into the eye. We don't want to image the macula only. We don't want to image the 2.5 millimeters close to the retina. We want to image deep into the vitreous. I'm a vitreo-retinal surgeon, so for me it's very important to know whether it's a PVD or not. And we do navigated peripheral OCT in every patient. Our staff knows that and automatically does peripheral navigated OCT imaging of every lesion that they find before the patient reaches my office.
And do you use peripheral OCT at each time before the photocoagulation lesion?
That's a very good question. Thank you very much. The answer is yes. I think nowadays we have to do image-guided photocoagulation. I don't believe in PRP at the first session. I believe in TRP, targeted photocoagulation. So I do fundus fluorescein angiography and OCT angiography-guided photocoagulation. So I start from the periphery towards the arcades. I think that the most important is to target the areas of non-perfusion and the transition zone. We published 2 papers already several years ago, randomized clinical trials, and I think that's the future. It's important to remember photocoagulation is not a one-off treatment because diabetes persists and diabetic retinopathy evolves. But you don't want to destroy all of the retina at the first session. You want to do the minimum necessary, and for that you need both fundus fluorescein angiography, ultra-wavelength, and now you do need OCT angiography, ultra-widefield as well.
Gia, do you think it is possible again to increase the depth in OCT over the 12 millimeters?
That's a great question. For the I don't know the secret for Dream OCT, definitely. Those, we need a very high-speed digitizer, very high resolution. Then we could generate the high-resolution spectrum, could extend the depth. I think now the speed of the I think the speed, what's that? In in our prototype, now the maximum we can generate is 6 millimeter imaging depth. The speed of the clock, because we need the clock, to match the spectrum for each wavelength. The clock, the internal clock, the speed, we couldn't really maximum, we couldn't further improve. So that's the net bottle to record all those tiny resolution of the spectrum, so we couldn't further improve. So that's why Dream OCT can achieve those extended 12 millimeter. I really want to discover further, how they could did that. Probably they have a high-speed clock, external clock. Probably they have a very good digitizer. They probably invested a lot of very good component on that. To be, beyond the, we have the question.
We have time for a last question from Professor Bart Leroy.
I hope I already
very
answered
briefly,
the question.
DICOM is becoming a standard for export of these type of images. Does DICOM come standard as an export?
We export the DICOM.
And how easy is it to see it on 20 view stations? Is it easy? Is it the software is easy to install and so on and so on? Because the acquisition is amazing. The images are amazing, but you then have to work. For example, I lead a Ghent University Hospital Department of Ophthalmology. We have 26 lanes, and we need to look at all the images. Is that easy? Because it's probably very heavy.
It's really easy and friendly software. Very easy.
It is possible, but that's what we also are sorting out ourselves with the company. It is very possible, so that you can remotely access the images. We thank all the speakers, we thank you, and we thank Intalight for organizing this session. Thank you very much.
Thank you.